Hi everyone, and welcome back to another MRI video with Corsmed. Today's topic and protocol is the anal fistula. We're going to do the entire thing start to finish inside the Corsmed MRI simulator. So going over to the simulator and let's go. Here we have the Corsmed MRI simulator, which is the tool I'll use to showcase this protocol. In MRI, we always face three core trade-offs: scan time, resolution, and signal to noise ratio. And if we improve one of these, it will negatively impact the other two. So how do we prioritize between these metrics when scanning for anal fistulas? Since we aim to visualize tiny fluid-filled tracts in soft tissue, we must have a high resolution to see these details clearly. We're also studying areas subject to movement from the bowel and other abdominal organs, so we need to keep scan time very short to avoid motion artifacts. So we mainly prioritize resolution to get the fine details we need to detect small or branching fistulas, and we keep scan time as our second priority to avoid motion artifacts. Now, what are the medical conditions we look for in an anal fistula MRI? First, we look for simple and complex fistulas, including intersphincteric fistulas. These show up as bright tubular tracts on T2 sequences, which make fluid appear bright against darker tissue. Simple fistulas typically run straight from internal to external sphincter, while complex ones branch or take indirect paths. We also assess for perianal and perirectal abscesses that can develop around the fistula tract. These appear as bright fluid collections on T2 fat-saturated sequences, which suppress fat to highlight inflamed tissue. The fat suppression increases the CNR, or contrast to noise ratio, between normal fat and abnormal fluid. Third, we check for inflammatory edema and cellulitis from prolonged inflammation. These conditions are best seen on T2 stir sequences, which completely null signal from fat to highlight edema and subtle fluid-related issues. The bright signal from edema helps us understand the extent of the infection spread. Finally, we look for post-operative changes, scars, and potential tumor involvement. These structural details are clearly shown on T1 sequences, which highlight fat, provide clear anatomical contrast, and helps us distinguish between scar tissue and active inflammation. When performing this protocol, there are also some things you should keep in mind. First, we need to check for motion artifacts after we complete each image and ensure we don't prolong the scan too much or make it uncomfortable for the patient. Second, because we're using long fast spin echo sequences, we need to consider fat suppression effectiveness and how much heating we give to the patient. So the limitations of SAR, or B1 RMS, are important here. Third, we also need to consider contrast to noise ratio, which is needed to clearly distinguish fluid from fat. Now, let's begin planning the protocol. We'll start by reviewing the patient positioning and hardware settings. I'll drag up my localizers, which show the pelvis of a female patient. There's an important point I want to make here about patient preparation. As you can see here, we failed in the correct preparation for the anal fistula exam. And we failed because of these black spots, the gas in this patient's bowel. Here, this bright blob in the middle is the patient's bladder, which appears filled with water that's hyperintense in these T2 weighted scans. So this is not an ideal setup for an anal fistula exam. The excessive air and gas in the bowel and the full bladder actually deform the rectal anatomy, which is here. As you can see, it's much bigger than it should be. The air and gas also increases the risk of artifacts because we're facing two very different intensities, water from the bladder and gas that's black. They create an interface, and this will impact our ability to saturate the signal coming from fat. So our fat suppression will fail if we don't prepare the patient correctly. These issues can also distort or cover smaller structures and pathologies during image interpretation. So we need to ask the patient to empty their bladder and avoid gas-producing foods like fiber before the scan if possible. When positioning the patient, we'll place them supine on their back and center the scanner's lasers in the middle of the coil, positioned on the lower abdomen. You can touch the coil's upper border with the patient's iliac crest. That will mark your upper limit. For the coil, we want to choose a pelvic or body-phased array coil. This type of coil improves resolution and signal-to-noise ratio for deep tissue structures. We'll use a 1.5 Tesla field strength and occasionally scan at 3 Tesla. Scanning at 3 Tesla can improve resolution, but it requires more careful fat suppression and artifact management. For gradient strength, we'll use a standard maximum from 30 to 45 millitesla per meter, as we're not running any EPI or fast gradient switching sequences. As for motion, we don't need to worry about it in our simulator here, since our simulated patient won't move. But in the real world, you should constantly review your images because this area is highly subject to motion artifacts. So let's go ahead and select our sequences for the localizers. We'll go to the correct folder and use the 3-plane localizers here. We can use the one from the rectum because the rectum and anus are often scanned together as they lie very close to each other. So I'll just add this and run the 3-plane localizers. Now they just finished. Once acquired, we can upload the images in each viewport and scroll to the mid slices for each one. We can start by inspecting this gray blob, which is the start of the anus and rectum. We can find it over here. This is the inner orifice of the anus, which will give us our angulation. Here is the main axis of the anus, and this is the main axis of the rectum. As you can see here, the rectum is actually full, so there's not only air or gas in the bowel, but also feces. In the axial, we can see the outer orifice, this little guy over here. To see the general anatomical coverage and landmarks, we need to focus on the sphincter and anal canal, this initial portion of it. We also need to cover the ischiorectal foci, which are these structures that come out obliquely and aren't visible right now in the localizers. We must also cover the perianal skin, lower rectum, and mid-pelvis soft tissue. Everything surrounding the anus could be affected by the fistula. For the key anatomical planning notes, we'll review them for each sequence. But generally speaking, for the axial sequences, we want to be perpendicular to the anal canal, this over here, highlighted by the orange line. It comes in a little more obliquely here. In the coronal, we want to be parallel to the canal. And in the sagittal, we want to go midline through the pubic symphysis over here. Now let's talk about the sequences we'll use. Remember, the protocol I'll show in this video, just a general standard. You should always tailor it to your institutional guidelines and to the clinical indications for your patient. Since this is a very common protocol, we often find it already built into most scanners. The core sequences we need are Sagittal T2 turbospin echo, the same sequence but with fat saturation applied, then an axial and coronal T2 as well, fat saturated. Additionally, we can sometimes have special add-on sequences with different types of fat suppression. We'll talk about them shortly. Sometimes we also find T1 weighted sequences with or without contrast, which may be used if we suspect a tumor, for post-operative assessment, or for surgery planning. Sometimes for research or advanced protocols, we may use diffusion-weighted imaging. We won't cover this last one, but we'll cover all the rest. Let's import them and review them one by one to understand what they mean. I'll move my fat-saturated Sagittal T2 straight after my non-saturated one. A normal T2 without fat saturation, but with high resolution, is useful to show bright fluid and clear soft tissue. This is especially helpful for simple or somewhat complex fistulas, such as intersphincteric tract fistulas. If we have a very complex fistula, we'll add fat saturation to this sequence to highlight fluids without signal interference from the fat. This helps us understand any complex issues better and analyze for collections, abscesses, or branching tracts. Suppressing the fat is also needed for associated findings like inflammatory edema and cellulitis, which can occur with prolonged inflammation. Fat saturation enhances the contrast of inflamed tissue, increasing the CNR, or contrast to noise ratio, we talked about at the beginning. And we run this sequence for all planes to understand the relationship and spread of the fistula. Then we run a T1 in a relevant plane where we see the fistula, or something suspicious like a scar, tumor, or chronic change to show structural or postoperative details. So to position the sagittal, let me make my interface clearer so we can see the slice lines and box view. Now, for the T2 sagittal high resolution, I'd recommend using a case-based radial acquisition if you're running sequences like blade or propeller, depending on your scanner. This allows very fast scanning while also keeping very high resolution, and this shorter scan time also means less risk for motion artifacts. In this case, I don't need to apply any motion correction technique because our simulated patient won't move. But with a real scanner, you can use a radial case-based acquisition for the sagittal plane to avoid motion artifacts. Now, we want to align our slices midline through the pubic symphysis. This is the midline, so I'll move it slightly here. We want to cover the full rectum, so I'll scroll through the slices where we can see the complete anatomy. In the coronal view here, I'll angle our slices a little to be exactly in the middle of the rectum. And in the sagittal view, we want to cover down to the buttock cheek and beyond to ensure we capture everything. We should also capture the upper part of the rectum, which in this case is very visible because it's black and full with feces. This T2 is acquired with 2 averages to decrease noise as much as possible. I'll save it, run it, and then open my sagittal T2 with fat saturation. But this time, we'll change this to spectral fat saturation. For this sagittal sequence, we need to copy the same positioning from our previous sagittal. Now, I want to quickly explain the different fat saturation techniques that the Corsmed MRI simulator supports. The first method is STIR, which is an inversion recovery-based method. It works by setting an inversion time relative to the fat you want to suppress. That intensity level gets nulled completely in the image. However, STIR isn't the first choice for this protocol. The preferred choice is spectral fat saturation, called 𝗟𝗏. It's a specific pulse, providing more robust suppression. Spectral methods are faster and are first line for abdomen scanning. However, if suppression is poor, like with 3 Tesla scans, or poor patient preparation, where there's this interface between water and tissue, then 𝗟𝗏 loses its capability to suppress fat. This is because 𝗟𝗏 is very sensitive to inhomogeneities in the magnetic field. This is where inversion recovery comes in, because it's less sensitive to field inhomogeneity. So if we're running 3 Tesla or scanning in emergency mode with an unprepared patient, we should choose STIR. I'll run spectral for the sagittal just to show the difference. Then I'll run everything else with inversion recovery because my patient isn't well prepared. We can copy the same sequence, then rename it to STIR, open it, and change the saturation method. Usually the TI for fat goes around 150 to 180 milliseconds. I'll use the lower range, 150. I'll then press save and run this sequence. Meanwhile, I can look at the axial. For the axial, I really want my non-fat saturated image so I can visualize the inner orifice of the anus, which is this one. My mid slice is parallel to that area over there. So make sure it's in the middle and covers everything. Here, we have a right-left phase encoding direction, which helps us reduce motion artifacts. Because we want to keep a small field of view and not lose resolution, we'll also apply oversampling or fold-over suppression. Now let's save and run this sequence. Next, we have the coronal sequence, which we will angle parallel to the anal canal. As you can see here, this is the anal canal. So I'll grab my package and go as straight as possible, parallel to the canal. I'll straighten here and make sure I also cover the horseshoe tracts and bilateral spread. I want to cover this area and this area behind the rectum as well. A common mistake here is to plan off-angle slices and not get the landmarks right. So spend a few extra minutes making sure your sequence is correctly visualized. Scroll through your localizers if you need to. Make sure your field of view is big enough to include horseshoe tracts and bilateral spread, mid-rectum to the skin's outer border, and all the anatomical landmarks we mentioned before. We'll then save and run this sequence. At last, we can plan the spin echo. This time, it'll be done in T1 contrast, and we will copy the slice planning from the Sagittal T2 we ran at the beginning. This will be a much slower acquisition because it's a normal spin echo, so you can use techniques like parallel imaging to speed it up. Because normal spin echoes are slow, many modern protocols use fast gradient echo or vibe type sequences for T1 imaging, especially for post-contrast. These are much faster than spin echo and are often acquired in a single breath hold, if abdomen included, or within a minute for pelvic imaging, and they typically used with fat saturation. For this sagittal acquisition, we are generally in the 3 to 4 minute range, which is quite slow. So this is why you should use parallel imaging to shorten the scan time. Always make sure you have the correct coil, as it prompts here. In this case, I don't have the correct coil, a multi-channel coil, so I'll switch off parallel imaging and scan without it for now. I'll accept this slower acquisition time, which we would get on a real scanner. But since this is a simulator, we will get our images faster. Now, we want to make sure we've copied the exact same planning as our sagittal with high resolution from the beginning. We typically scan this right before giving contrast. So if I were going to administer contrast, I'd rename this to be pre-contrast and then save. Then I'd clone this sequence and run exactly the same one, but post-contrast. Ideally, this is a bolus injection, so it doesn't need perfusion or an injector. You can just run this, then inject the patient, and run the post-contrast as well. Because we don't yet support contrast injection for this body model, I won't run the last one. Let's now review the images we've acquired so far in our image viewer. I'll just wait for the last one to appear. You can see it here. Then I'll go to my image viewer and open my last Sagittal T2 turbo spin echo with high resolution. I want to scroll through the slices and visualize the pelvic anatomy here. Then I want to look for bright tubular tracts in the area of the anus. In this case, we don't have any abscess or fistula because this simulated patient model doesn't have any pathology. But typically, this image is used to check whether the fistula reaches the anal sphincter or goes further into the anus or rectum. Then we have the axial spare we acquired. As you can see, it didn't do a good job with fat saturation. You can see here, this isn't fat saturated, this isn't fat saturated either. This skin around the gas and bladder area isn't saturated at all. As I mentioned before, while spare sequences are faster, they may result in poor fat suppression because they are very sensitive to field inhomogeneity. So we need to switch to stir acquisition with inversion recovery instead. For stir, we have much better suppression. You can see that all structures here appear saturated except the muscle. This is a leg muscle coming in. So this is our inner sphincter, and here we have a better fat saturation. If you do have fluid collecting in the fistula, you should see a bright channel branching out from the anus here, which is dark. Such fluid collections in the fistula are very helpful to identify small side tracts and edema. That's it for the sagittal. Let's now look at the stir with axial projection. Here we can see the outer sphincter coming in. This is usually the most diagnostic sequence because it shows the tracts going from internal to external sphincter clearly and visibly. We will look from the area here, this is the internal sphincter, down to the outer. We want to look all around over here, all around in this skin area. For the coronal, we'll review the spread or horseshoe tracts, the ones that come sideways obliquely and aren't as well visualized in the axial view. The coronal highlights bilateral and translevator spread if they go up obliquely. Unfortunately, it's hard with this case because it doesn't present pathology. But a teaching tip I can give is to really make the best use of fat saturation, because if there's pathology, you'll see bright signal across the fat and very bright signal from abscesses or inflammatory fluid. Finally, I also want to show the T1 acquisition here. As you can see, the fat hasn't been saturated at all because we didn't apply fat saturation. We did this for demonstration purposes only, because if there's a mass or anything of that nature here in T1, it could be seen very quickly. So with that, we have covered the entire anal fistula protocol. Let's recap with the most important takeaways you need to remember. First, we generally prioritize resolution, then scan time, and lastly, SNR. High resolution is critical to see tiny fluid-filled tracts in soft tissue. And we must also maintain a short scan time to reduce motion artifacts. SNR is of course always important too, but resolution and scan time has special priority. Second, make sure your patient is correctly prepared, empty of all gas and fluid in the bladder. Poor patient preparation can affect both signal-to-noise ratio and our fat saturation quality. Make sure to adjust suppression techniques depending on patient preparation. If preparation has been poor, there's no point running spectral saturation, so go directly for the inversion recovery technique. Third, we mostly use T2 high-resolution sequences for this study, both with and without fat saturation. T2 is the best contrast for detecting fluid, such as fistulas, abscesses, or edema, because fluid appears bright on T2 images, and fat saturation improves this further by suppressing the fat signal, which is normally also bright on T2. Finally, avoid the common artifacts when scanning for anal fistulas, which include motion, susceptibility, wraparound, chemical shift, and fat suppression failure. Motion is the primary artifact, which you can mitigate by communicating clearly with the patient so they don't move, and also reduce scan time using parallel imaging or radial K-space acquisition. Also, if you're using parallel imaging to make it faster, make sure you use the correct coil. To avoid the other artifacts, you can use turbospin echo instead of gradient echo sequences, use large enough field of view and activate fold-over suppression, increase the bandwidth, and choose stir over spectral fat saturation. Follow these 4 points and your anal fistula scans will turn out great. I hope you found this tutorial useful, and I look forward to seeing you in our next session.